Hello, my name is Ian Cole, and this is the overview for Module 3B. Now in this particular module we're going to be looking at some of the red papules and nodules and a little bit on the principles of excision and curette and cautery. In derm path we're going to look at the histopathology of BCCs and actinic keratoses and a little bit on the dermatoscopy of hemangiomas. I think our tutorial topic is going to be juvenile xanthogranuloma. So, you should have had a look at this particular video. The video will look at the images that are in this particular module, especially those of the red papules and nodules. So, certainly have a good look at that. We'll spend a little bit of time looking at pyogenic granulomas. Now, I've said there that these are primarily poorly named lesions. They're seen particularly in pregnant women and they're seen in young children. In pregnant women they probably arise because of the angiogenesis factors that are involved in pregnancy. You know, you've got to produce all these vessels in the fetus and in the placenta. And typically it's usually in later pregnancy when women develop these, usually in the last trimester, and they grow very rapidly. So they're benign proliferation of capillary blood vessels. We'll go into the management of them in the webinar itself. We're also going to look at this condition, and this condition here is Fabry's disease. Now, Fabry's is an inherited disorder. It'll typically present as with a young male with angiokeratomas on the scrotum and angiokeratomas elsewhere. And typically this young male will complain of painful fingers. And it's the most curious presentation, but angiokeratomas with painful fingers. It's a disorder of lipid metabolism and they can present with quite marked renal problems as well, but we'll go into this one in more detail. The other conditions, I've listed scabies there as being a red nodule. Most of you are going to be able to diagnose scabies. The time when you see the red nodules is down on the scrotum. And it's virtually a diagnosis if you see those lesions. Sometimes they're off the scrotum, in the anterior axillae, sometimes in the groin, and there are these sort of plum-coloured nodules. Now, if you were to see these, they could equally represent lymphomas. And it's not the first time that someone's done a biopsy of a rather large scabetic nodule and had a report come back as a potential lymphoma, because of the very heavy infiltrate of lymphocytes you'll get there. Now usually there's going to be some eosinophils in there as well, and that would make the diagnosis of lymphoma less likely. But these have been, usually they may be diagnosed as a pseudo-lymphoma. So just remember scabetic nodules as there are hypersensitivity reaction to the scabies mite. Doesn't mean to say there's active scabies there at that moment. It's just a hypersensitivity reaction to the scabies organism. So remember that. We're also going to be looking at hemangiomas. Remember, these are also vascular proliferations. The majority aren't present at birth. Usually it's in the first month or so, and typically these lesions will involute with time. There's quite a bit of new therapy for some of these nowadays, especially if they're in a potentially dangerous area. And those potentially dangerous areas are if you've got them near the eye, near the mouth, near the nose, you know, the nose where they can make breathing difficult. The problem with the eye is if they block one eye, then the child may be functionally blind in that time because they never developed normal binocular vision. So you've got to get them shrunk down. And the big advance there is in the use of beta blockers. And one of the cases that we've in fact got to look at this week is going to be on the use of beta blockers in the treatment of hemangiomas. So we'll go into that in some detail in the actual webinar itself. What else? There's a couple of other red papules and nodules you should know about. Always remember sporotrichosis. This is where you have a red nodule that progresses its way with a series of them coming up lymphatics. In other words, you have sporotrichoid spread. Usually there's been a penetrating injury to the skin and the sporotrichoid organism has been implanted deep in the skin. Skin heals over, then it starts to proliferate about a month or so later and a nodule will come up. Sometimes they're smooth like this, other times they're more verrucous on the surface. But once they start to spread up the lymphatics, then you think of sporotrichosis or you think of atypical Mycobacterium marinum being the two likeliest things that are going to do that. So you need to know a little bit about the treatment of sporotrichosis. This lesion here is an unusual red nodule that again I'll speak a little bit about. This is bacillary angiomatosis. And this is seen in HIV patients. It's an infective disorder, a bacterial infective disorder. We really don't see it much at all, but the lesions look like giant pyogenic granulomas. So, an interesting condition to read up a little bit about. Kaposi sarcoma, that's one of the classic vascular tumours along with angiosarcoma. There was the Kaposis that occurred in elderly Jewish males, particularly in Poland and the Eastern Europe, and they begin with a bluish discoloration on the foot and slowly it would enlarge over a long period of time to become very verrucous like this. But then the other time Kaposis was seen was in patients with HIV disease. It was one of the earliest presentations. Remember, this is due to one of the herpes viruses, probably herpes virus 8, and it really relates to your number of T cells, how immunocompetent you are. If your immunocompetence goes off, then this thing will come up. If your immunocompetence comes back because you're perhaps on highly active antiretroviral therapy, then sometimes these Kaposi's lesions will completely disappear. The morphology variations in Kaposi's is quite remarkable. Bruise-like lesions, verrucous lesions, flat plaque patches on the skin, large nodules. So a little bit about Kaposi's. I think that was, the other thing that we did want to talk about were glomus tumours, and we will talk about that. Now, most glomus tumours that you're going to see are going to be painful, small discolorations, purplish discolorations under a nail, and that's where you're most likely to see these lesions. But you can get glomangiomas where you get more than one lesion seen elsewhere on the body, and so you can get whole clumps of them together, and look like blue leopard bleb nevus syndrome, or even Kaposi's it might look at, but they certainly look like vascular tumours. The single glomus tumour is usually painful, and multiple ones usually aren't. Again, you get proliferation of these blue glomus cells round vascular channels. Glomus cells represent a means of, they're a myoepithelial cell, I think, and they represent a means of either opening or closing channels, bypassing part of the capillary bed. But we'll show further pictures of those in the webinar itself. This was one where a guy had a glomus tumour on the ear. You can see how vascular it in fact looks. Now, as well as some of the red nodules and papules, we're also going to go on and look at a surgical topic. And the surgical topic is just the basic principles of excisions. We'll go into that in a little bit of detail. You should have again looked at this particular video here. I've given links to lectures in MD Live. It's a bit much to try and go through all of these just now, but have them for reference only, and if you're looking for additional information on preoperative assessment of patients or the action of local anaesthetics, then come back and click on these lectures and have a look at them. There's quite a lot of detail in this MD Live lecture series. Skin tension lines are the most important factor in skin excisional surgery. So, and it's primarily on the face that you have to be well aware of skin tension lines. I think my own view is that on the trunk, it's the shape of the lesion that's more important rather than the skin tension lines in deciding the direction in which your ellipse is going to go. And I'll repeat that I think it's the shape of the lesion that determines the direction of the ellipse on the trunk and the chest, rather than skin tension lines. But skin tension lines are quite useful on the face, certainly on the distal arm and on the leg. So make sure you've looked at some images of skin tension lines. Anatomy is obviously very important in the carrying out of skin cancer surgery. You've got to know the major nerves, the major branches of the facial nerve, and the areas where they're most likely to be damaged. For instance, over the zygoma here, for the superficial branch of the temporal nerve. So that's so dangerous up here. It's more back here where you've got the main named root of the nerve, where you're more likely to do damage, just over the zygoma there. Again, the mandibular branch of the facial nerve, down near the notch just anterior to the masseter muscle. You can generally feel the artery here as well, and the nerve lies just deep to it in this area. You have to go down fairly deep after these. It's only if you've, say, got an infiltrating or a recurrent tumour there that you're likely to go deep enough to actually prang that particular nerve. So I think these are probably the two major areas where you're most likely to do damage to a branch of the facial nerve. But you should know the named branches of the facial nerve and roughly where they run, whether they're superficially deep to the parotid or running through the parotid itself, and the areas where they're most superficial. Okay. The key parts about curettage and electrodesiccation. Well, curettage is quite a good technique. As dermatologists, we do a lot of curette and cautery. The main point about doing a curette is that the base, you've got a dermis to work on, because unless you've got a firm dermis, you can't curette away the soft tumor tissue. So, there are a few areas on the face per se where you can easily do curette and cautery, and there are some areas where you certainly can't, particularly around the eyes, where you've got very little dermis at all. If when you're doing a curette you puncture right through the dermis into the fat tissue, in other words the tumour's gone right down that deep, then essentially you've got to abandon doing your curette and you've got to actually excise the lesion. I'll sometimes curette lesions up here on the forehead, but they'll generally be small lesions. You don't curette recurrent lesions, you don't curette infiltrating lesions. You mainly curette superficial BCCs and small nodular BCCs. So, know a little bit about curette and cautery. Know a little bit also about skin cancers in areas prone to deep extension, such as the embryonic folds on the face. That's particularly these folds here, embryonic folds here as well, and behind the ear. These are where in the embryo the tissues coming in and meeting in the midline for the development of facial structures. A few other details here about curette and cautery. Is there any cancer left behind after curetting? Well, we hope that there isn't, but on many occasions where I've initially done a curettage, and then decided, no, I think I'll excise this. Yeah, it's amazing how many times there are some small areas of skin cancer still there. I think the fact that we get such good results from curette and cautery is that in the healing process, I think some of these remaining islands of tumour in fact die off because we've disrupted their blood supply. Now, electrosurgery, read a little bit about this, know the difference between electrofulguration and electrodesiccation. You know, in electrofulguration, the needle of the hyfricator is held above the skin surface, and you get the sparks from the tip of the needle down to the skin surface. And electrodesiccation is where the needle touches the skin surface. Usually we just use a little bit of electrofulguration, probably with most of the things that we in fact treat. The issue of pacemakers and electrosurgery, I think nowadays there isn't really much of an issue at all. Most modern pacemakers are not affected by the use of these electrosurgical instruments at all. It might only be if someone, if you're operating on something directly over a pacemaker, then it might be prudent to use an actual cautery, just a heated platinum wire type cautery in those circumstances rather than electrofulguration. Remember, with curettage, it's serial curettage. We're talking of taking several layers away with the curette and cautery technique to make it qualify for curettage, or for the curette and cautery item number, the 30196. What else? Other things that you can use the hyfricator for, spigioangiomas, really quite useful for that. This little lecture here on the variations of the basic elliptical excision I thought was quite good. I've said it's for reference only there, but again, if you've got time, I think this is quite a good MD Live lecture to have a look at. And we've just mentioned Mohs surgery here. We'll obviously go into Mohs surgery in much greater detail later on in this course, but I think it's important early on to have an idea of the advantages of Mohs surgery. Basically, it relates to the way in which the specimen is handled. When you're cutting the specimen out, you usually cut it beveled in the way at 45 degrees. The reason for that is you're then pressing the outer aspect of the excised lesion so that the whole of the exterior is at the same level as the base. And this is then frozen and it's sectioned horizontally so that you've got the base of the lesion in the center of your round excision, your round dermatome cut, and round the outside you've in fact got the periphery of the excised lesion. And all of this is stained and examined, so you're then able to examine the whole of the outside of your excised specimen. And that's the importance of Mohs surgery. You're examining all of the periphery of the excised specimen, as against bread loaf sectioning, where you may be only examining a horizontal section at 3 or 4 points through the tumour. And we've shown before how you may miss a part that's extending beyond the edge of the excision line. So Mohs surgery is primarily a means of examining the whole of the excised edges of the lesion that you've excised. This little bit I thought was important. I'll go into it a bit more detail in the webinar itself, and that's when to consider referral of a patient elsewhere. And I think these are all good. You know, recurrent infiltrating BCCs, particularly on the face and neck. They can go deep. They can go much deeper than you think. They can go much wider than you think. You're going to have normally to take at least 7mm margins, sometimes even more, around where you think the edge is to make sure you've got this out. Again, poorly differentiated SCCs, especially any that have perineural spread. Be that be SCC or BCC, but particularly SCC, those things can extend quite widely around the excision site, and you often end up having to do wide field radiotherapy as well. Yeah, this one, skin cancers involving the external auditory canal. bad area. If they get in, if they're in the conch and then they move towards the canal, if they're in the canal, it's a devil to try and get them out. So always refer those. They often have to split the area, open it up so that they can get in there, remove it and graft it. Skin cancers involving the lips, watch those. I mean, most of the time you'll be equipped to do a wedge excision and you'll be taught how to do a wedge excision, but a poorly differentiated SCC involving the lip, especially in a background of actinic cheilitis, the metastatic rate is somewhere between 15 and 20% for an SCC. And you've got to always feel the submental glands, always feel the cervical glands. I must admit, if I've got a poorly differentiated SCC of the lip, I usually refer it off because you've got to take wide margins, so it's a big wedge you're going to have to take out. Also these extensive scalp lesions, especially if the scalp's bound down. The scalp's going to bleed in the majority of patients. It's a difficult area to excise. You generally have to do big rotation flaps to get a relatively small area of coverage. If I had a small triangular area like that, you'd have to do a big rotation flap back here to be able to close that relatively small defect. And they all bleed, so I must admit, I refer off extensive scalp lesions that can be done in hospital rather than my rooms. And we've already mentioned skin cancers with perineal invasion and spread. So we'll discuss these, see what your thoughts are during the actual webinar itself. Might have a look at some of these images later as well. Now the derm path topic for this particular module was the dermatopathology of BCCs and I think some sort of keratosis. I've said here, if you're doing a lot of skin cancer work, you've got to have some idea of the histology of the lesion that you're biopsying. You want to know what it is before you're going to be doing your excision, because your margins with BCCs in many ways are determined by the histopathology. There are some aggressive histological subtypes of BCCs, particularly the morpheic or infiltrating or the micronodular and the recurrent BCC. The superficial BCC isn't too big an issue, except it may have skip areas and it may extend a bit beyond where you think the edge is. So it's one of the reasons why, either curetting or even freezing superficial BCCs, they tend to recur out at the periphery, simply because there have been some nests budding off there from the base of the epidermis that you just haven't seen. Let's have a little look. Have a look at that video. It goes into more detail on these particular images here. But I think this first image here was going to just show, your superficial BCC. If you look at that edge, you'll sometimes see little papules, a little pearly edge here. And if you look at it dermatoscopically, it's linear, fine serpentine vessels. Let's see if we can make that a bit bigger. That you'll tend to see running through this, as against the glomerular vessels that you're going to see with an SCC in situ. Let's look back. This is the histology of the superficial basal cell skin cancer. It basically buds from the basal layer of cells at the base of the epidermis, and you get this palisading, peripheral palisading around the outside here. So that's the classic feature of a superficial BCC. You can appear to get sort of normal areas in between as well, the skip areas. That's a more nodular basal cell skin cancer. Again, some superficial buds. So you can get a mixture of superficial and more solid or nodular basal cell skin cancer. We'll talk about the sclerosing BCC during the lecture itself. These are some micronodular BCCs coming down here, with a more solid bit here. This one we'll talk about in the webinar. It's the fibroepithelioma of Pincus. Look at that reticulate pattern of the BCC. These things often look pinkish, often on the legs as well. They may make you think there's a clear cell acanthoma from the clinical colour. Then there was this guy with infiltrating BCCs. Look at the infiltrating BCC, where you've got these strands going in and a big bit of stroma in between. We'll talk about that in a bit more detail as well. Then we're also going to look at actinic keratoses, the various features of actinic keratoses, and these are some of the subtypes. The typical, the acantholytic, where you've got separation of some of the cells, some of the keratinocytes. The hypertrophic actinic keratosis, where you've got a big thick layer of stratum corneum. The lichenoid one, where you've got a lymphocytic infiltrate hitting the base of it, so it becomes a bit inflamed and red. A boinoid actinic keratosis, where the pathologist can make his mind up whether it's a full SCC in situ or just an actinic keratosis. And the pigmented actinic keratosis, it's a very distinctive thing clinically. So this is just the histology we'll go into in some detail, usually an area of parakeratosis, layered parakeratosis overlying where the actinic keratosis is. This is your lymphocytic infiltrate here, giving a bit of a lichenoid reaction to it. This is the pigmented actinic keratosis. It can look a bit like lentigo maligna, and it can be difficult. We'll chat a little bit about the dermatoscopy of that during the webinar itself. Now, we're also going to look at the dermatoscopy, I think it is, of hemangiomas and angiokeratomas. Pretty straightforward, you know, it's red or purple clots basically. That's what you're going to see in the vast majority of cases. And these will be the angiokeratomas of Fordyce, the ones that are seen in the elderly on the scrotum. Remember, if you see a lot of these sorts of lesions in a young man, then consider he may have Fabry's disease. There are some rare vascular tumours. We've already talked about bacillary angiomatosis in AIDS patients. There's Kaposi's sarcoma. Sometimes, as in this particular case, you know, you'd be forgiven for thinking that was just some form of angioma. You know, red structureless area, some white septae there. But this, in fact, was there was a non-AIDS associated Kaposi's sarcoma, in fact. This we'll talk a little bit about during the webinar itself. I'll go into this in more detail. This was an angiosarcoma, and you can see it's a diffuse bruise-like lesion that the patient in fact has. But it's this is what the dermatoscopy looks like. Some dot vessels in there, but also some thick linear vessels. In other words, there's just a proliferation, if you look at this histologically, there's just a proliferation of these vascular channels lined with some atypical endothelial cells. But remember, angiosarcoma in the elderly will often present with bruise-like lesions like these on the head and neck area. And it's rare, it's a tough diagnosis, not a good diagnosis either. If you can get them when they're small, then sometimes wide excision and grafting can cure it. But generally, when they get to this stage, surgery just won't work, and radiotherapy doesn't work either. But there are some new monoclonal antibodies that are being used in treating this as well. And this was just, watch the combinations of a lymphangioma, which are the clear bits here, with hemangioma as well. Well, there's hemorrhage actually into the lymphatic, dilated cystic channels here. This will often leak clear fluid or perhaps some blood fluid as well. So usually lymphangiomas have some associated vascular abnormalities as well. In the webinar we'll look at juvenile xanthogranuloma. Solitary one is usually not of great significance. Multiple ones, you have to look at the child from the point of view of having one of the histiocytoses, and you've also always got to check the eyes. But we'll show some further examples of that in more detail. And we're going to look at a couple of cases. in the webinar itself. I think the first one was this one in the virtual clinical meeting. Was one of the cases that was presented to Dermo of a little baby with this thing on the cheek and a more rapidly proliferating vascular area here. You can see this greyish bit, almost as if there's a little bit of involution occurring here already. But the issue was, should one use topical tenopterol in this, or should one use oral propranolol, or should one do nothing at all? It was interesting to have a little, I'll add some more comments that people have made in there before the actual webinar itself. And we also wanted you to look at these two cases that are in Global Skin Atlas. One was on ecthyma and one was on macular amyloidosis. I want to talk about both of those if we've got time. So that's an overview of what we'll look at in Module 3B. I hope you get a chance to go in and have a look at some of the information we've got there, perhaps some of the references. And if you've got some questions, bring them up during the webinar itself. I appreciate there's a lot of stuff in this just now. Just choose the bits that interest you most. Try and have a little listen to that video there. It'll give you a better overview of the range of red papules and nodules that you might see. Thank you very much.